Welcome back to week 2 of the Coronavirus Chronicles. Today we're going to talk about C. diff colitis and Ischemic colitis. I think that every surgeon should be well versed in the management of C. diff colitis. It is an all too common postoperative problem. As you can see from this chart, the number of cases is steadily increasing. In 1993, there were approximately 90,000 cases. In 2018, there were approximately 450,000 cases, so a five-fold increase. In 2018, there were about 29,000 deaths attributable to this infection. C. diff infection is clearly associated with antibiotic use. Antibiotics can have the unfortunate side effect of wiping out the normal commensal bacteria of the colon, leaving behind toxic species like C. diff. Not every strain of C. diff produces disease, but the ones that do produce two toxins, A and B. Toxin B is the one that causes diarrhea. It increases the colon mucosal cells' permeability to water. Toxin A seems to be responsible for the degree of the immune response that can happen. Some patients develop a very fulminant course of this disease, and it's postulated that toxin A causes a very overzealous cytokine response that can result in all the manifestations of septic shock. Antibiotic usage is the major risk factor for C. diff infection. The most commonly implicated agents are the fluoroquinolones, clindamycin, cephalosporins, and the combination penicillins like Zosyn and Unison. These are all antibiotics that are commonly prescribed on a surgical service. There are some other additional risk factors, of which the most interesting is the use of proton pump inhibitors. C. difficile is not a normal bacteria found in our colon, and so it has to get there somehow. Presumably that's by ingesting it. And it seems that an acid environment in the stomach is protective against C. difficile infection. The clinical presentation of C. diff infection varies quite a bit. Most patients have a mild watery diarrhea. However, some patients can present with sepsis, toxic megacolon, and perforation. The problem usually starts around 4 to 9 days after antibiotics were prescribed, but about 25% of patients may show up as late as 10 weeks after a course of antibiotics. And these antibiotics can be a prophylactic dose or two. It does not have to be a long-term therapeutic prescription. Most patients have watery diarrhea. They'll have at a minimum 3 loose stools, but the number can be as many as 10 in a 24-hour period. They also might have some lower abdominal pain, a low-grade fever, with some anorexia and nausea. Physical exam is usually fairly unremarkable, with perhaps some lower abdominal tenderness. Overall, these patients don't look or act terribly sick. However, some patients quickly develop more serious symptoms. They can develop diffuse abdominal pain and distension, and they can become rapidly hypovolemic with an elevated creatinine. Their lactic acidosis, if it were to be measured, is also likely to be high. They can also develop some very dramatic white blood cell counts. Fortunately, only a small number of people progress to the fulminant variant of this disease, but this is where most of the deaths will occur. These patients can rapidly develop shock and multisystem organ failure. These patients come to the attention of the surgeon because they may well develop a perforation or toxic megacolon, And again, their white blood cell counts can be extremely elevated. About 20% of hospitalized patients are asymptomatic carriers for C. diff. As far as I'm aware, no infectious disease society recommends screening for these patients or treating them if they're known to be carriers. One challenge in treating patients with C. diff infections is that about 25% of patients relapse within 30 days after they finish their treatment. And this relapsing disease can be more serious than the index disease. One major risk factor for this is in patients who need ongoing antibiotics for another infection. For instance, if someone needs 6 weeks of antibiotics to treat osteomyelitis, and then they develop C. diff, after they are finished treatment for C. diff, they're still going to need their antibiotics for the osteomyelitis, setting them up for another bout of C. diff. C. difficile infection is diagnosed by testing for C. difficile toxins or for the C. difficile toxin B gene. There are several different tests available, each with their own advantages and disadvantages. We'll go through one approach, but keep in mind different institutions may approach this somewhat differently. Of the several tests we'll talk about, they all have the advantage of being cheap with a very fast turnaround time. Generally, you can get results back within 1 hour or so. One possible approach is to use a GDH Antigen Test. This basically looks for antibodies for a specific enzyme that is present in all C. difficile species. This is a useful test because a negative test means that you're very unlikely to have C. difficile infection. A positive test, however, isn't so useful because it can't distinguish between the toxigenic and the non-toxigenic strains. In other words, it has poor specificity. In conjunction with the GDH antigen test, both the toxin A and toxin B should be tested for as well. In this case, a positive test is extremely useful. If you have the toxins, you're quite likely to have C. diff infection. However, there's a very high rate of false negatives here, so the sensitivity is low. So what do we do with these results? Well, if both tests are positive, then we consider the patient to have a C. diff infection and we'll treat him as such. If both the tests are negative, then we'll consider the patient to not have a C. diff infection. But what do we do if we have discordant results? One test is positive, the other is negative. We need a way to break the tie. The Tiebreaker test is a polymerase chain reaction test for the gene that encodes toxin B. A positive test here is considered strong evidence of a C. diff infection as long as one of the first two tests was also positive. The name Clostridioides difficile colitis is relatively new. The disease we're talking about today used to be called Pseudomembranous Colitis. The tests that we just finished talking about were not yet available, and the only way to diagnose this disease was with endoscopy. If you saw these characteristic pseudomembranes, that was considered to be diagnostic for an antibiotic-related colitis. The problem is in mild disease, only about 25% of patients have the characteristic pseudomembranes. As the disease gets more serious, then the likelihood of seeing these pseudomembranes increases. Nowadays, we never need to do an endoscopy to diagnose C. diff colitis. The only time an endoscopy would be considered is if there's some other pathology on the differential that needs to be ruled out by direct visualization or biopsy. Once a patient is diagnosed with a C. difficile infection, hospital infection control practices need to be initiated. The patient should be isolated in a private room, and all personnel who have to work with the patient need to gown up and glove up. Of course, hand washing is critical since this disease can be passed from patient to patient via an intermediary like a doctor or nurse. Some propose that soap and water is more effective than alcohol-based hand sanitizers since C. diff spores may well be resistant to alcohol. The medical management of a C. diff infection begins with stopping the offending antibiotics, if at all possible. If the patient requires ongoing treatment for an infection, then at a minimum they should be switched over to additional antibiotics that are less frequently implicated in C. diff infections. Of course, fluid electrolytes need to be replaced. These can actually be very large. Some of these patients have voluminous amounts of diarrhea. It is surgical tradition not to use anti-motility agents to stop the diarrhea. I'm not aware that the evidence for this is particularly strong, but most recommendations are not to do it. If the patient has a mild course of the disease and they can tolerate a diet without making the problem worse, then they do not have to be NPO. For patients with mild disease, oral vancomycin is the preferred treatment. Alternatives are oral metronidazole or oral fidaxomicin. The treatment course usually is for 10 days. In patients with the more severe variant of this disease, higher doses of antibiotics are used, and sometimes a second agent will be added if there's no response to the first. If the patient can't take medicines orally, then they can be given via an NG tube. In very refractory cases, vancomycin can be given as an enema, but this is associated with a fairly high rate of perforation. Fortunately, only a small minority of patients with C. difficile infection will require surgery. So, what are these indications for surgery? And then, what possible operations are there for you to do? And what will be your go-to procedure? So I'll think about this for a second or two, and then we'll answer it. Some patients who require surgery for C. diff infection develop a perforation. At the time of surgery, it would be highly enticing to do a segmental colectomy and just remove the perforated segment. Unfortunately, that seems to be associated with a near 100% mortality rate. Of course, this makes a certain amount of sense, as C. diff colitis is a pancolonic disease, and so only removing a small segment of colon is leaving most of the disease behind. Of course, the more radical procedure, a total abdominal colectomy with a stoma and either a mucus fistula or a Hartmann's pouch, also is associated with a very high morbidity and mortality rate. Nevertheless, if you have to operate on one of these patients, removing the entire abdominal colon is the way to go. Of course, you still have to deal with the residual rectum. That has disease as well. And one way to manage this would be to put in a tube before you leave the operating room. This could be a mushroom-tipped Mallinckrodt catheter or even a Foley catheter with a 5 to 10 cc balloon. Again, stitch it in place so it doesn't fall out, and then post-op, the residual rectum can be flushed with a vancomycin solution. Because of the very high mortality rate for an abdominal colectomy, a newer procedure has gained some traction in the last several years. This is a minimally invasive loop ileostomy, and then through this ileostomy, you flush the colon with a go-lightly type solution in the operating room. Of course, you need a rectal tube in place to collect the effluent. And once you're done with this, the patient can go back to the ICU and they can get daily flushes through this ileostomy with a vancomycin type solution. There are several published reports in the literature that seem to suggest very good results, at least compared to typical abdominal colectomy results. Survival appears to be better. The ileostomy reversal rate is better. One downside to this approach is that the patients are slower to recover. In other words, it can take several days to see the effects of these lavages. In any event, if you're interested in this approach, it's something you might ever consider if you were faced with it. SAGES has some videos about this on their website. Before we finish with C. difficile infections, just a brief word on fecal transplants. This is a procedure that can be highly effective in patients who have multiple episodes of recurrent disease. There are some patients who, once they stop antibiotics, develop the disease again. And this can be a recurring theme that goes on for some time. In these patients, a fecal transplant can be highly effective and almost immediately curative. Okay, let's shift gears now and talk about ischemic colitis. A brief refresher on anatomy. The right side of the colon is supplied by the superior mesenteric artery, and the left side by the inferior mesenteric artery. There's a very extensive collateral network between these two arteries, primarily via the marginal artery. There is a separate vessel, the arc of Riolan, although not present in a majority of people, serves as a secondary collateral source. The colon receives anywhere from 10 to 30% of the cardiac output. If flow drops by about half, ischemia then is prone to develop. This ischemia develops typically in two so-called watershed areas. If we look at the attached picture, and specifically at the splenic flexure, you'll see that it receives its blood supply from two arteries, the left branch of the middle colic, as well as from the left colic. The splenic flexure is far away from the origin of both of these vessels. What this means is that if flow is compromised through these vessels, the splenic flexure is going to feel it first, especially if the marginal artery in this area is in any way compromised. A similar situation occurs in the rectosigmoid area. In this area, blood supply comes from the superior rectal artery as well as from the internal iliac. Again, this is the terminal end of these vessels. And so in low flow states or obstructive states, blood supply will be less the further you get from the origin of the vessels. Most cases of ischemic colitis are related to non-occlusive causes. Cardiac pump failure would be common in a medical ICU, as well as shock from sepsis. In the surgical ICU, shock from hypovolemia or vasopressors is also a common non-occlusive cause. Medicines like Levophed are remarkably efficient at closing down blood supply to the colon. Occlusive causes are much less common. Embolism to the left colon almost never occurs. The only real occlusive cause of any import would be IMA ligation. This may well happen during a repair of a AAA or an aortobiFEM operation. Ischemic colitis is classified by the degree of thickness. Most cases are related to ischemia of the mucosa and submucosa only. These typically resolve with nonoperative management. In some patients, this can be a repeated process and long-term could result in stricturing or scarring. If a patient develops full thickness ischemia, then perforation is likely to result with the resulting urgent surgery. The clinical presentation is dependent on how much of the bowel wall is involved. For patients with partial thickness disease, the typical presentation is a left-sided abdominal pain, often cramping. There can be a low-grade fever, and bloody diarrhea is characteristic. If someone has full thickness disease, then they'll have peritonitis. They may well be febrile. They'll have a leukocytosis and a lactic acidosis. Plain films can be obtained quickly, and their primary value is to look for free air indicating perforation. One sign that can be seen that suggests ischemic colitis is so-called thumbprinting, as seen by the arrow here. Most patients with abdominal pain are going to get a CT scan. The CT findings for ischemic colitis are nonspecific. Wall thickening is one finding that has been associated with the disease. Fat stranding would be another. This patient clearly has very advanced disease and probably belongs in the operating room. Patients who develop bloody diarrhea will need an endoscopic evaluation. This picture shows a very pale, sort of sickly looking mucosa, certainly consistent with ischemic colitis. Although the endoscopist can only see the mucosa and not the entire thickness of the bowel, this mucosa clearly is dead, and it wouldn't take much imagination to believe that this is full thickness disease. So what do you want to do with the patient who, let's say, is postoperative day 2 from an aortic revascularization? They develop left-sided abdominal pain and have several episodes of bloody diarrhea. On your exam, there's some mild tenderness, but no peritonitis. So what's your plan? So the goal for these patients is to maximize cardiac output and increase mesenteric blood flow. Fortunately, about 80% of patients respond to this and will require no surgical type intervention. The patient may well benefit from being made NPO. If they're distended or nauseous, an NG tube can be helpful. These patients may well require fluid resuscitation for any concomitant low flow state. Broad spectrum antibiotics are usually prescribed. The theory behind this is to prevent translocation of bacteria. I'm not sure the evidence for this is compelling, but it is the most common thing to do. If they're on vasopressors, if they can in any way be stopped, that needs to happen. And for those few patients that don't improve, then one's going to have to make a decision about going to the OR or possibly repeating a CT scan or endoscopy to see if the disease is progressing. Okay, let's finish up. Who needs surgery for ischemic colitis? And what operation will you do? While the typical indications would be an acute abdomen, any free air seen on imaging, massive hemorrhage, which is unlikely, or any evidence of full thickness necrosis on imaging or even by endoscopy. Your typical operative approach will be segmental resection of the ischemic area. This could be done open or laparoscopically, depending on your skill set. In almost all cases, these patients will require an ostomy and either a mucus fistula or a Hartmann pouch. A primary anastomosis should almost never be considered in this patient population. We're dealing with low flow states and poor blood supply, and your anastomosis would be highly tenuous if you chose to do it. In fact, if you have any doubts about blood supply, you don't even have to make a stoma at the first operation. If you want to come back for a second look and reassess, that's perfectly reasonable. It's rare, but if the entire colon is involved, then a total colectomy and ileostomy would be necessary. Okay, thank you for your attention. We'll continue on next week. We will talk about primarily colon cancer and a few words about colon polyps.